Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 158 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, the cardiologist believes CRE needs a root canal and seeks your recommendation and counsel to the patient on antibiotic prophylaxis to prevent infective endocarditis, i.e. So my question to you is, which of the following would be the most appropriate to recommend for CRE? Would it be A. Give ciprofloxacin 250 mg orally 1 hour before the procedure, or B. Give amoxicillin 500 mg, 4 capsules orally 1 hour before the procedure, or C. Give ampicillin 2 grams IM 1 hour before the procedure, or would it be D. No prophylaxis is necessary? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Give amoxicillin 500 mg, 4 capsules orally 1 hour before the procedure. Dental prophylaxis for IE should be reserved for the highest risk groups, which include those with prosthetic cardiac valves. That makes answer D incorrect. Antibiotic therapy should be targeted against streptococci in the oral cavity, making answer A incorrect. The oral route is also preferred because of the potential adverse effects of intravenous administration, making answer C incorrect and answer B is correct. Kindly transit to the next question. And the next question reads, patient CRE returns to the clinic in 30 days with a chief complaint of a 2-week history of fatigue, decreased appetite, and low-grade fever. Several sets of blood cultures have been obtained, and transesophageal echocardiogram, abbreviated as TEE, is scheduled for later in the day. Considering CRE's presentation, the physician is concerned that the patient has IE. So my question to you is, which of the organism listed below is the most likely cause of CRE's infection? Is it A. viridans group streptococci, or B. coagulase negative staphylococci, or C. Pseudomonas aeruginosa, or is it D. Staphylococcus aureus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. viridans group streptococci. Given the patient's history, the most likely source of the IE is poor dentition. Viridans group streptococci are most highly associated with this source, therefore answer A is correct and answers B to D are incorrect. Please progress to the next question. And the next question reads, LHP, a 9-year-old lad is brought to your accident and emergency department with a chief complaint of new fever and chills in the past 24 hours. 2 weeks ago, the patient was initiated on co-trimoxazole treatment for left lower extremity osteomyelitis caused by methicillin-susceptible Staphylococcus aureus (MSSA). He is allergic to co-amoxiclav and he developed a rash with co-amoxiclav treatment at age 2. On physical examination he has a body temperature of 39.4 degrees Celsius and a grade 2/6 diastolic murmur. LHP is initiated on vancomycin and admitted to the hospital. Transthoracic echocardiogram, abbreviated as TTE, reveals a 1.6 cm vegetation on the mitral valve. Several blood cultures grow MSSA, so my question to you is, which of the following regimens would be the most appropriate for LHP now? Would it be A. change to gentamicin plus cefazolin, or B. change to cefazolin, or C. add gentamicin to current antibiotic, or would it be D. continue current antibiotic? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. change to cefazolin. The causative organism is MSSA, making answer B, cefazolin, the correct answer. Answer A is not ideal, given the lack of improved clinical efficacy in a patient with a native valve or uncomplicated endocarditis. Vancomycin should be reserved for patients who have an allergy to, or intolerance of, beta-lactam antibiotics because it is inferior to beta-lactam regimens in the setting of bacteremia. That makes answers D and C incorrect. The patient's allergy to amoxicillin clavulanate is most likely a type 4 allergic reaction and would be unlikely to cause a cross-sensitivity with cefazolin. Please move on to the next slide. And the next question reads, you are assessing patient outcome for patients referred to the outpatient parenteral antibiotic therapy clinic before and after a pharmacist was involved. Your primary endpoint is a composite of adverse effect experienced by patients and all-cause hospitalization. So my question to you is, which statistical test would best compare these data? Would it be A. Mann-Whitney U, or B. McNamara test, or C. Paired t-test, or would it be D. chi-square? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. chi-square. The primary endpoint measured is nominal data from two unrelated groups, therefore, a chi-square test, answer D, would be the most appropriate test. The paired t-test and McNamara test are both used in assessing related groups. That makes answers C and B incorrect. The Mann-Whitney U test would be the most appropriate to assess ordinal data, which makes answer A incorrect. Please transit to the next question. And the next question reads, JPF, a 57-year-old male patient presenting for a follow-up to implantation of an implantable cardioverter defibrillator, abbreviated as ICD 14 days ago. He has a past medical history significant for prostate cancer, hypertension, hyperlipidemia, celiac disease, and non-ischemic cardiomyopathy. He has a chief complaint of erythema, pain at the site of implantation, and a low-grade fever. His pertinent labs include a white blood cell count (WBC) of 6.8 times 10 power 3 cells per millimeter cubed, an ESR of 35 millimeters per hour, and a CRP of 13.2 milligrams per liter. Blood cultures at 24 hours show no growth. JPF is being prepared for surgical debridement of the infection and device removal, and the cardiothoracic surgeon asks for antibiotic recommendations post-operatively. So my question to you is, which of the antibiotic regimens listed below would be most appropriate for JPF? Would it be A. ceftriaxone plus vancomycin, or B. daptomycin, or C. meropenem, or would it be D. no additional antibiotics? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. ceftriaxone plus vancomycin. Removal of the device is insufficient for a device-related infection because there is evidence of extension of the infection into the surrounding soft tissue. That makes answer D incorrect. Empiric antibiotic treatment should be directed at MRSA, ruling out answer C given the patient's medical history of prostate cancer and celiac disease. Gram-negative bacilli should also be considered for coverage, making answer A correct and answer B incorrect. Kindly progress to the next question. And the next question reads, CHT, a 48-year male patient is brought to your accident and emergency department unconscious and in respiratory distress. He is revived with a dose of naloxone. He has a chief complaint of fevers, chills, dyspnea, and chest pain over the past week. The patient is well known to the accident and emergency department personnel and admits using cocaine and injecting heroin when he can afford it. His last heroin use was a few hours before presentation. He has a past medical history significant for right upper extremity cellulitis, and hypertension. His physical examination is significant for a grade 3/6 systolic murmur, painful erythematous nodules on the pads of his fingers. His chest X-ray is negative for opacities or consolidation. A TEE is performed after a negative TTE reveals a 7 mm vegetation on the tricuspid valve. His pertinent vitals include a blood pressure of 162 systolic and 90 diastolic, a heart rate of 98 beats per minute, a respiratory rate of 24, and a body temperature of 39 degrees Celsius. 3 sets of blood cultures identify Staphylococcus aureus with the following susceptibility. The pathogen is resistant to ampicillin and erythromycin, and susceptible to clindamycin, gentamicin, levofloxacin, coccinellin, rifampicin and vancomycin. On admission, the patient was initiated on vancomycin and piperacillin, tazobactam. The patient is stabilized, and repeat blood culture shows no growth at 24 hours. So my question to you is, which of the following would be the most appropriate recommendation for CHT's antibiotics? Would it be A. initiate nafcillin and add for a 4-week course, or B. continue vancomycin and add gentamicin for a 2-week course, or C. initiate nafcillin to complete a 2-week course, or would it be D. continue vancomycin to complete a 4-week course? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. initiate nafcillin to complete a 2-week course. The patient has uncomplicated right-sided infective endocarditis and is eligible for a 2-week course of therapy. The identified organism is MRSA, and the patient has no history of intolerance to beta-lactam antibiotics, thus, the vancomycin regimens would not be ideal. That makes answers D and B incorrect. Data support a short course of a beta-lactam alone in this setting. Adding gentamicin has been associated with increased toxicity and no improvement in clinical outcome, making answer A incorrect. Please advance to the next question. And the next question reads, GJC, a 39-year-old female patient presents to your hospital with a chief complaint of a 2-day history of fevers, chills, malaise, and dyspnea. Over the past 24 hours, she has also developed unremitting substernal chest pain. Her pertinent labs include a WBC of 14.2 times 10 power 3 cells per millimeter cubed, and a rapid influenza test is positive for influenza A. Her pertinent vitals include, a blood pressure of 124 systolic, 80 diastolic, a heart rate of 68 beats per minute, a respiratory rate of 24 breaths per minute, and a body temperature of 38.9 degrees Celsius. An electrocardiogram reveals PR segment depression, and an echocardiogram is positive for a small pericardial effusion. Blood and sputum cultures are pending. So my question to you is, which of the following would be the most appropriate to initiate at this time? Would it be A. Ibuprofen plus oseltamivir, or B. Oseltamivir, or C. Ibuprofen plus prednisone, or would it be D. Ibuprofen? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Ibuprofen plus oseltamivir. The patient tests positive for influenza A, and likely has a secondary viral pericarditis. Ignoring the influenza infection would be inappropriate because the viral pericarditis would likely continue to worsen throughout the infection, making answers D and C incorrect. Answer B would address the influenza but would not improve the inflammatory component of pericarditis. Answer A is the only option that addresses both the infection and the inflammation of the pericardium. Kindly progress to the next slide. And the next question reads, CTR, is a 69-year-old male patient with a height of 67 inches, and a weight of 72 kilograms on day 6 of 42 for treatment of infective endocarditis caused by Enterococcus faecalis. The patient initially presented with 2+ pitting edema in his lower extremities, fatigue, decreased appetite, and shortness of breath, which have all improved. The only new finding is decreased urinary output over the past 2 days. His labs from yesterday include a WBC of 7.6 times 10 power 3 cells per millimeter cubed, a serum creatinine of 2.4 mg per deciliter. It was 0.8 mg per deciliter 4 days ago. And gentamicin trough is 2.6 mg per deciliter. His current antibiotics include gentamicin 60 mg IV thrice daily and ampicillin 2 grams IV every 4 hours. His pertinent vitals include a blood pressure of 134 systolic and 80 diastolic, a heart rate of 68 beats per minute, a respiratory rate of 16 breaths per minute, a body temperature of 37.2 degrees Celsius, and his oxygen saturation is 97% on room air. He has a past medical history significant for systolic congestive heart failure, CHF, and infective endocarditis 2 years before the current admission. So my question to you is, which would be the most appropriate recommendation for CTR's antibiotics? Would it be A. Discontinue current antibiotics and initiate daptomycin 500 mg IV every 48 hours, or B. Discontinue gentamicin and initiate ceftriaxone 2 grams IV once daily, or C. Change gentamicin dosing to 200 mg IV once, followed by a concentration to assess interval, or would it be D. Discontinue gentamicin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Discontinue gentamicin and initiate ceftriaxone 2 grams IV once daily. A change in therapy to daptomycin, that is answer A, is not warranted at this point, given the improvement in the patient's clinical symptoms of infection and WBC. The patient is, however, experiencing nephrotoxicity while receiving gentamicin therapy. Although small studies support a shortened course of gentamicin therapy, 2 weeks versus the treatment duration, it is only day 8 of treatment and is too early to discontinue combination therapy, therefore answer D would not be optimal. Answer C is not optimal because the patient is already experiencing nephrotoxicity with gentamicin therapy, and extended interval dosing lacks adequate data in enterococcal endocarditis. Adding ceftriaxone would be the most appropriate option at this time, making answer B correct. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 159.